Okay, it looks like it's 8 o'clock, everybody. Welcome back to GIM Grand Rounds. Thank you for joining us online. For those of you who are doing so, this morning we have Dr. Fernando Holguin, who's professor of medicine in the Division of Pulmonary Sciences. He went to medical school at La Salle University in Mexico City and did his residency in internal medicine, fellowship in pulmonary critical care at Emory. He is the director of the clinical and research programs in asthma here, and we've asked him to come and speak with us about updates in asthma therapy. So Dr. Holguin, thank you for being here. Looking forward to your talk.
Thank you for the invitation. Thanks for being here this morning. This is going to be, my goal is to give you kind of a brief update into what's been new about managing asthma in terms of inhaled therapy. I know you probably have heard there's a lot of development around biological therapy, but there's been a lot of growth in terms of clinical data around how we use inhalers and how we treat symptoms. And so I think this talk is going to focus a lot more on that aspect of asthma management. So those are my disclosures. And just to get a little bit on some basic terminology. So when you talk about air is when you dose people with inhaled corticosteroids or formoterol, which formoterol is a long-acting, rapid onset drug that can be used as rescue. Or when you do that with albuterol plus budesonide, only to relieve symptoms, that's called anti-inflammatory rescue therapy. And SMART or SMART is when you use, for example, inhaled corticosteroids and formoterol twice daily, but also you allow the patient to use it as rescue. So in this equation, there's just no room for albuterol, basically. So those are the basic terminology. So the objective today is to really outline some rationale for using this type of therapy. Maybe I'll talk a little bit about some data that supports why do we use MART and AIR versus usual care. And then talk about some of the challenges and some of the uncertainties regarding this therapy and some of the guidelines and barrier to implementation and affordability. I give this talk talking about like how do we do it worldwide. So I'm not talking about the international aspect of this, which is a huge problem because most countries cannot afford this therapy. Okay, you can see the point, right? So for those of you that are old enough to remember, basically asthma management used to be, prior to this concept, used to be get people on albuterol unless they have more than symptoms twice a week or more than one nocturnal per month. And that was basically, if that happened, then you move into inhaled corticosteroids plus albuterol. And that was sort of the management of asthma for a very long period of time. But there are really several problems with that. First of all, it's not really supported by any specific data. As I'll show you, patients with mild disease can have severe exacerbations and severe airway inflammation. So there's really significant discordance between symptoms and exacerbation risks. So the fact that the patient is telling you, hey, I'm not having a lot of symptoms doesn't necessarily really preclude them from having a severe exacerbation. And we know from earlier data that adherence to daily inhaled corticosteroids is really poor. So I was telling Mark that the best case scenario is you could get people to be adherent 40–50% of the time, but not beyond that. And people tend to use short-acting beta agonists a lot more than they should. And that's just that, and it's bad for them, as I'll show to you. So I'm glad we moved from that into thinking more creatively and I think more pathophysiologically about how to treat these patients. So a couple of things about mild asthma. So mild asthma, people think that mild asthma is just mild across the board, but the reality is there's a disconnect between mild symptoms and exacerbation risk. So I just pulled some data for you, but people with, for example, with mild asthma that are treated with short-acting beta agonists alone can have as much as 1 to 3 exacerbations per year. Many of them, about 30% of them, can be quite severe, requiring hospitalizations or emergency room. Some of 5 to 13% of asthma deaths were on people with mild disease. And in asthma death studies, 15 to 20% of patients had symptoms less than weekly in the previous 3 months. So in the National Review of Asthma Deaths, 9%, 10% occur in people being treated for mild asthma. So I want you to think that mild asthma has nothing to do with severe exacerbations. People with mild disease that are in a day-to-day basis having very little symptoms, they get the right type of virus for them and they can end up in the hospital or end up in the ICU. So this is what, in the old literature, we didn't make that connection very well. So it's a sort of a little bit of misconception that mild asthma is mild across the board. It refers mostly to day-to-day symptom control. Years ago, this is one of the earlier studies. Years ago, one of the things that people showed is that if you add a long-acting beta agonist, in this case, this is expiratory flows, peak expiratory flows, morning and evening peak expiratory flows in people treated with salmeterol, in addition to inhaled corticosteroids, versus just inhaled corticosteroids. And as you can see by the darker bars on the top, if you give people a long-acting beta agonist, they do much better. The lung function improves. And so when salmeterol came up, people were very excited about it. But, at the same time that we're starting to think about more about giving people more beta agonists for longer periods of time and pharmacologically longer acting drugs, there's very good epidemiological data that showed, for example, this is from the Saskatchewan Asthma Epidemiological Project in the Northwest, showing that if you follow people over time, this is 12,000 patients, 47,000 person year follow, very long study. You can see there's an inflection point in terms of asthma deaths. So if patients use more than 2 canisters per month, epidemiologically, the rate of asthma deaths paradoxically goes up. So when you start thinking that using a lot of beta agonists leads to worse asthma outcomes, right? So people starting to recognize gee, maybe it's not a good thing to give people albuterol that much. In this study by Apollo Byrne, this is a very interesting study, small study where they took people and treated them with albuterol, 2 puffs every 6 hours for a week, for 10 days. And these are people that had known allergens, so they were exposed to a known allergen that they were sensitive to. So here you can see in your left side of the screen that once they were exposed to allergens, their FEV1 dropped in the early phase reaction, and then sort of it comes down. And then in the late phase reaction, that's the way your airway typically responds, bronchoconstriction and their airway inflammation. But so this is people treated with placebo here and with albuterol. So what's really striking is that people that were treated with albuterol for a whole week, when exposed to an allergen challenge, actually did worse than placebo. They actually bronchoconstricted more. And not only that, but at 7 hours had higher levels of sputum eosinophils. And if you look at exercise challenges, this study also from Paulo Byrne and McMaster's, what they did is they took people, spam never misses. So these are people that were known to have exercise-induced asthma, and they were treated for a week with albuterol, and they were re-exposed to an exercise challenge. And what you can see here in the screen is that people with the albuterol, which is the open dots, actually did worse than people that were treated with placebo. So if you follow the line, is treating people with albuterol constantly without having some degree of anti-inflammatory therapy is not a good thing, both for exercise response and allergen responses. And then this very famous meta-analysis, which published in the Annals of Internal Medicine, came out that took a lot of trials that were people were being treated with salmeterol, which is a long-acting beta agonist. And what they saw is that there was in this meta-analysis, was about 2.5 odds for having severe asthma exacerbation or an asthma-related death. So people was like, wait a minute, we're giving all this drug to people for asthma, and they're doing worse, and they're actually dying more. But a hint, you cannot see here in the bottom of the screens, only about half of these studies that use salmeterol were people on inhaled corticosteroids. So many of these trials were just with salmeterol, on which we don't do in asthma. It's actually contraindicated. There was a very famous study, it was called the Salmeterol Multicenter Asthma Research Trial, which is called the SMART study, in which people were treated, one of the arms was treated with salmeterol alone. And they've actually saw an increase, statistically significant, although small, asthma-related deaths and combined asthma-related deaths and life-threatening experience in people treated with salmeterol compared to placebo, particularly in blacks that were not treated with inhaled corticosteroids. And this was a trial that led to the FDA to put a black box on the FDA. Until very recently, put a black box to all these drugs and said, these drugs should not be treated for first-line asthma management. Whereas at the same time, Advair was like, you got to put your patients on Advair. This is the best drug in the world, right? So that went for a long time, until this New England Journal of Medicine study in 2019, which the FDA said, you guys need to get your act together. And what they did is they harmonized all these studies. Basically, they harmonized the outcomes and evaluated outcomes on 36,000 patients. So it's a huge study, post-hoc analysis. And what they found is that people that were treated with combination therapy, actually with inhaled corticosteroids, had lower risks of death no different than other arms, but also in the combined analysis did better than inhaled corticosteroids. So after this study actually showed that it was safe to use in a large patient population, as long as you do it with inhaled corticosteroids, the FDA removed the black box warning on salmeterol, which is not there anymore. And why do we combine albuterol with inhaled corticosteroids? Actually, pharmacologically makes a lot of sense. So acutely, I thought about this for a while because it didn't make sense to me, but acutely, when you give people corticosteroids, you actually, in the airway epithelium, you increase the density and expression of beta-2 receptors in the airway. And when you give beta-2 agonists, you actually favor the localization of glucocorticoreceptor into the nuclei, thereby providing better anti-inflammatory therapy. And these things happen rather acutely. So pharmacologically, it makes a lot of sense to combine beta agonists and inhaled corticosteroids. They pharmacologically synergize with each other to improve outcomes. Let me know if there are any questions. Since we're a small group, we can make it more of a talk, conversational. Paul O'Byrne, who was a great guy from McMaster's, who's done a lot of this work, was here recently. You know, in this original study, they hypothesized that if you use these things together and you allow patients to use inhaled corticosteroids and bronchodilators at the same time when they're having symptoms, that then they would have a better response because they would adjust their anti-inflammatory therapy when they need it the most, which is basically the essence of smart therapy. It's like when the patient has symptoms is the time to administer anti-inflammatory therapy. And what they did in this study in 2,700 patients, they were randomized to budesonide and short-acting beta agonists, which is SABA, budesonide formoterol and SABA, or they were doing just budesonide formoterol maintenance and relief. So that this arm would be called SMART. SMART, remember that it's as needed inhaled corticosteroids and formoterol, but also in a maintenance fashion. And you can see that those in SMART, they overall had much lower rate of exacerbations throughout the study, throughout a year, but they also had better lung function, reduced amount of exacerbations, reduced amount of oral corticosteroids, and less amount of emergency room visits. And they did that. All these outcomes happen. If you look at this graph, this is the amount of rescue, the amount of times that people actuated rescue throughout the study. And this is day since randomization. You can look at the dose in the SMART arm used a lot less rescue medications. So even though they did better, they used rescue medications. Yes, ma'am. Yeah, so the third arm was budesonide formoterol maintenance and relief, which is the same drug, just as needed. Yeah, yeah. So basically, this is giving people Symbicort or something like Symbicort because it's a turbohaler in Europe. Symbicort twice daily, plus use your Symbicort if you have symptoms. So no albuterol. So this is what we do. This is what we tell patients. Yes, Rita.
They differentiate between regular like mild asthma versus people who are classified as exercise.
In this particular study, these were people that were, I think, considered sort of GINA 2-3 moderate asthma for these particular studies. Most of the studies vary between moderate and mild. So we lack a little bit of data on people with more severe disease, which is one of the limitations of this therapy. But they don't make distinctions whether they're exercise or not, because there's a lot of heterogeneity in the population. What about AIR? What about anti-inflammatory rescue therapy? In this study, 4,000 patients, GINA step 2, so kind of mild to moderate disease patients, were randomized to use terbutaline, that's budesonide formoterol as needed, and budesonide maintenance. So they were just saying, you know, when you have symptoms, use your formoterol and inhaled corticosteroid as needed. So there was no maintenance. It's just anti-inflammatory rescue, or continue using your inhaled corticosteroids on a daily basis plus albuterol. I think in this case was terbutaline, which is what they use in Europe. And you can see that the probability of having an exacerbation was identical in both arms, right? So there's actually non-inferiority. So just telling people, hey, use your Symbicort whenever you have symptoms is as good in terms of exacerbation prevention than you have to be on an inhaled corticosteroids every day. They work exactly the same. Despite having a little bit, these people in this study, people on the as needed had a slightly reduced lung function compared to the other arm, but still the outcomes, the clinical outcomes were the same. More importantly, in this study, so a lot of people in this line of work were thinking, you know, we have to really be careful about how much of the results that we're seeing are related to the fact that they're on a clinical trial. What about real world data? So this was a real world data, open label study, 668 asthmatics who had been treated with only SABA monotherapy. So people that came in the study had never been on inhaled corticosteroids, just a short-acting beta agonist for at least 3 months prior, and had evidence of exacerbations in the past. And they were then randomized to air versus inhaled corticosteroids and budesonide or SABA alone. So for example, here you have the studies. Those that were treated in the budesonide for motoral group had lower rates of high use rescue utilization, had lower rates of urgent care, had lower use of systemic corticosteroids, and the exacerbations were equally between those that were treated with budesonide for motoral group versus budesonide maintenance, so inhaled corticosteroids. It gets a little confusing. But when you look at severe exacerbations, those that were treated only with budesonide for motoral had lower rates of severe exacerbations requiring emergency room or hospitalization. So again, showing that this therapy does work. This is from this study, again, showing that the reduction on exhaled nitric oxide, which is a marker of inflammation, was similar in both groups and much greater in those just treated with albuterol alone, and that the rate of exacerbation was the same in both groups, ICS or ICS maintenance or anti-inflammatory rescue therapy. But I think the benefit of this study is that these patients, look at that, 73, this is a median dose in micrograms daily. So you went from patients taking 247 micrograms of budesonide compared to 73. So patients benefited equally, took a lot less inhaled corticosteroids, and did better or the same. This is another study about 300 patients that actually one of the concerns was, I think the reason why these patients do better is because they overutilize rescue therapy. So the study meant to look at utilization of high utilization days, and high utilization days were looked at people that use more than 8 puffs per day. So here's people on the SMART therapy compared to standard therapy. And so people in SMART therapy actually use less rescue therapy, are less on systemic corticosteroids, and have the same amount of serious exacerbations. So this kind of gets repeated again and again in multiple studies, pretty much regardless of the population that you see. The bottom line is that this therapy is non-inferior to inhaled corticosteroids, but it actually reduces even better severe exacerbations. So in this post-hoc analysis of 12,000 patients, that took data from 5 double-blind randomized trials, it's a huge study. I'm just kind of highlighting, this is asthma people that achieve control based on GINA criteria. So taking the open arms is budesonide for motoral, which is the open squares, maintenance and reliever therapy. So SMART therapy compared to either high maintenance daily ICS or same maintenance ICS LABA or higher maintenance dose ICS LABA, it's better in terms of control, at least compared to ICS SABA. But then I think the real benefit is when you look at across different stages of severity, step 2, step 3, or step 4, being on SMART therapy, which is the open bars, leads to lower reduction of severe exacerbation rates compared to any of the other arms, regardless of the dose of inhaled corticosteroids. That's the take-home message is, this is a summary of different odds ratios of different studies, is that overall air is better than using albuterol as needed or albuterol as needed plus inhaled corticosteroids, and MART is superior in terms of exacerbation reduction compared to inhaled corticosteroids and long-acting beta agonists and albuterol alone. So less medication for better or same outcomes. And the reason why this works, I tell the residents when we're in clinic, think about an exacerbation happens like a normal curve. You start to have a little bit of symptoms, and then more symptoms, and then more symptoms, and then more symptoms. Then you peak, and then you're very sick, and then you get better, and slowly you recover. So the basis of this therapy is to dose people at the early part of the curve. It's like when you begin to have symptoms is when you need to dose therapy. In the past, we used to tell people, if you're having symptoms, use your albuterol, and that was okay, but that only treated one component. That only treated bronchial constriction without treating the inflammation. And so what happens with many of these patients is you take away the bronchoconstriction, but inflammation goes unabated. And in some cases, it can continue to get worse. And if the patient continues to take a lot of albuterol, then what you have is some degree of tachyphylaxis in which the albuterol doesn't work anymore, and that's when the patients die, end up in the ICU. That makes sense? So I think that the reason why this therapy works is because it's all about the right timing. So this is a very nice study, a post-hoc analysis, about 4,000 patients. People looked at different studies combined, and these are people that were randomized to as-needed short-acting beta agonist, in this case terbutaline, which was done in Europe. We don't use it in the US. The red ones were as-needed budesonide or formoterol. And then the green ones were budesonide maintenance plus as-needed short-acting beta agonist. And basically the question of the study is, excuse me, these people were being monitored very carefully. And so they knew in a study, the analysis basically asked the question, what is your risk of having an exacerbation 3 weeks out after you start to use more rescue above baseline? Does that make sense? So if I never use and I start to use more than 2 a day, then what is my risk of developing an exacerbation 3 weeks down the road? That was the essence of the analysis. And so in this particular study, the majority of patients at some point in the study used more than 2 inhalations. A smaller proportion used more than 4 inhalations, and then 6 and then 8 inhalations above baseline. And so when you look at the Cox proportional modeling, it's really interesting because the blue line over here are those that were on the albuterol or terbutaline arm. And so those that started using rescue with terbutaline had a much higher rate of exacerbations, as you can see here, 3 weeks out. This is using 4 or more, and the risk of exacerbation 3 weeks out after that episode. Whereas those that were treated with inhaled corticosteroids or as-needed therapy did not exacerbate. And again, the reason is either you're on fully anti-inflammatory therapy or you dose people when they need to be dosed, and then you reduce the risk of a subsequent exacerbation. And this is what's really neat about this therapy. So there's some special considerations that I think are worth talking about. One of them is, what about the use of budesonide formoterol in patients taking salmeterol fluticasone? So can you, for example, give somebody Symbicort if they're taking Advair, for example, right? What about its utility in preventing exercise-mediated exacerbation? Does it mitigate airway inflammation as well as being on maintenance? So I'm going to tackle these 3 questions, not perfectly because there's not great data, but we have some approximation. So this is data from the RELIEF, which was a 6-month open label study that randomized 18,000 patients to basically evaluate as needed formoterol or salbutamol on top of maintenance therapy. The basic essence of the study was like, is formoterol safe and effective? But in this post-hoc analysis, they looked at what happens when you add formoterol to people that are already taking salmeterol, like if you do formoterol in somebody taking Advair. And what they saw in this large post-hoc analysis is there's a much larger increase, about 2.5 times more likely than those taking albuterol on top of on those formoterol therapy. Those on the salmeterol therapy that then went on to formoterol had a higher rate of discontinuation for therapy and then non-asthma related adverse events. Not only that, but if you take maintenance ICS formoterol, like if you're taking a Symbicort and then you add formoterol on top of it, you still get a benefit on the reduction on exacerbation rates. But if you look at people that were on salmeterol and then you gave them formoterol, there was no benefit. So basically the message is adding formoterol to salmeterol, it's associated with a higher rate of adverse events, both asthma and non-asthma adverse events, and does not prevent exacerbations as well. So in general, these are 2 drugs that you should not mix together. And patients often do because they don't know. And so I'm always like asking patients in every visit, tell me what you're taking. And they always tell me, it's in the chart. And I know it's in the chart, but you tell me what you're taking. And it's always surprisingly when people tell you what they think they're taking and what the chart says. Rita, to your question, these are 66 patients that all had evidence of exercise-induced bronchoconstriction and were randomized to either daily budesonide, daily albuterol, or budesonide formoterol as needed. They were treated for 6 weeks and then they were re-exposed to an exercise challenged. So what you're seeing here is the effect, the drop in FEV1 after being re-exposed to an exercise challenged. And those that were on albuterol alone had the sort of the lowest reduction in FEV1 after exercise, which is very similar to a study from Paul O'Byrne that I showed you at the beginning. So if you treat people with albuterol alone, and then they exercise, and they're sensitive to exercise, they're going to drop more. A caveat, though, this readout does not answer what's the utility of albuterol before you exercise. Basically, this looked at what is the effect of maintenance therapy on an exercise challenge. All of these patients were told to withhold therapy 24 hours before the exercise challenge. So the study did not look at use your albuterol before. I don't know that we've done studies in which we tell people take Symbicort before exercise or take albuterol before exercise. If a patient only uses albuterol before exercise and they love it and they do great, I just say go for it. I sort of that's one of the things that you have to just see what the patient likes and prefers. There's not really a lot of good data for that. Does that make sense? Doesn't really quite answer the question. What about airway inflammation? So if you compare, for example, people in high dose maintenance therapy, budesonide versus as needed, people in the maintenance therapy, which is the darker the squares, tend to have lower airway inflammation based on eosinophils. But the outcomes, which is the percent of events here in this graphic over time, is the same. So again, in many of these studies, you have a little bit of drop of lung function, you have a little bit more airway inflammation, but overall, people do the same. So we really don't care. Yep.
Just doing it on the maintenance, you would expect the inflammatory effect to be 24, 36 hours later. So is there a frequency effect, or like the people that respond, are they using it 5 days a week, or?
Yeah, so that's a really good question. So I think the issue is that, yeah, so you're asking whether or not like using as needed, basically.
Versus using it 5 days a week. Is that
Yeah. Yes. So I think that the issue is that controlling inflammation at check can have carryover effects that last days or weeks. And that's probably what you saw on that study where they looked at the rate of exacerbation. So the question is for this particular study, for example, if you in those that were on the as needed, they didn't do as bad. They did sort of comparable to those who were on daily inhaled corticosteroids when exposed to a challenge. And the issue is that they somehow control their inflammation based on symptoms sufficiently enough that they could be exposed to an exercise challenge and not do worse. So that's one of the nice things about this therapy. Yep. Yes. So the question is, on drugs that don't contain formoterol, can we use them like mometasone and formoterol, like Dulera? I'll get to that point. Okay, so what is the standard? What is the global initiative for asthma saying that we should manage patients? So for people that are on across the board, basically, if you look at this, the rescue inhaler of preference is as needed low dose ICS formoterol for stages 1 for the disease severity 1 through 5 all the way through. For people that are on stages 1 and 2 of GINA, so those people with mild day-to-day symptoms, basically what you tell them is use it as anti-inflammatory rescue only. Like somebody that has symptoms twice a week, perfect. You would do perfect on Symbicort as needed, right? Or Air Supra, which we'll talk a little bit about that. For people that have more frequent symptoms and requiring step-up therapy, like here's in step 3, 4, and 5, what we recommend is for them to be on maintenance and rescue at the same time. So MART moves stage 3, 4, and 5, where people with mild disease can only do anti-inflammatory rescue therapy. There's some discordance between the Global Initiative for Asthma Management, the GINA, and this is the NAP guidelines that I was on the steering committee. So we ended up recommending this type of maintenance and rescue therapy only for stages 3 and 4, but still stages step 1 and 2, still the NIH recommended just albuterol, which I think is just their appraisal of the literature at the time. I tend to really think that this is not the best way to go. The best way to go is to use anti-inflammatory rescue therapy all the time. Even the European Society guidelines definitely suggest that for people that are on step 1 and 2, use ICS and formoterol as in a single inhaler as a preference. So, and they recommend against using short-acting beta agonists. Yes. Yeah. Yeah. So I'll talk a little bit about some strategies. Those are very, very good questions. So are there other forms of providing anti-inflammatory rescue therapy? So you may or may not know, this just came on the market. I was in the part of the committee of the FDA Pulmonary Drug and Allergy Committee that approved it. The data is actually pretty favorable. So this medication basically takes albuterol plus budesonide. Okay, so it's an albuterol plus, if you think about it. So it's called AirSupra, and it comes in 2 doses, 180 and 180 and in 80 and 160 budesonide, and albuterol 180 micrograms. So this study that compared 3,000 patients, poorly controlled, that were either on maintenance ICS or ICS LABA, that were randomized into using high or low ICS SABA as rescue therapy or SABA alone. And patients that were on albuterol budesonide in the higher dose had lower rates of exacerbation throughout the study. So you can use albuterol and budesonide. It's another thing you can use. And actually that makes sense on people, for example, that are on triple therapy, once a day triple therapy. And this study, actually, to your point, Rita, this is a study that's called the PARTIX study. It's a very interesting study, mostly in Black and Latino patients, Latinx patients. It was a pragmatic PECORI study, open label, randomized 1,200 Black and Latinx adults with moderate severe asthma. And it was a very neat study because it happened a lot through COVID. And what they said, it's very, very simple. Patients were only seen once, and they followed remotely throughout the study. And what the study said, hey, every time you use your albuterol, I want you to follow it with a puff of your inhaled corticosteroids. That's it. That's it. Nothing else. There's no added medications. That was the intervention. And you look at this study, it was in New England Journal of Medicine. The hazard ratio was lower in those that used their budesonide after using the albuterol compared to those that used albuterol for rescue alone. So, 20% reduction on exacerbation is not trivial, right? It leads to some benefit. And patients, even though this was not statistically significant, they tended to have better control and better symptom control. And throughout the study, this only led to a 1.1 extra inhaler per year. So this is what's interesting. It doesn't require that much, and it leads to very tangible benefits. So these were people that were, underrepresented minorities, not a lot of access to more expensive medications, and they say, hey, just chase one after the other, right? Albuterol and then inhaled corticosteroids. If you do that, every time you have symptoms, it leads to a 20% reduction on exacerbation rate. So you don't have to go through an expensive medication. It requires a lot of training and patient participation because, you're asking them to use 2 drugs instead of 1 when they have symptoms. But there are some alternatives, I think. So there's been a number of really high power editorials. These people, you may or may not know, but people here, for example, in this editorial are pretty much some of the sort of thought leaders in asthma management. And I think what people are saying is that we should do away with albuterol. I mean, I think the albuterol it's a dying breed, basically, because now we have a better therapy than albuterol alone. So this will answer some of your questions. So the Helen Riddell, who is the chair or the director of GINA, published this paper recently with Michelle Cloutier and Jerry Krishnan and others that have done a lot of work on this area, and Eric Bateman, basically asking, kind of like answering some practical questions about implementing smart therapy. So what is the recommended dose? So once a daily or twice daily of 160 dose of the Symbicort in step 3, and then 2 inhalations at 160 dose twice a day, plus as needed in step 4. You can do, as well, I tell patients, a max of 12. There's good data that even up to 12 puffs per day is safe. Because people ask me, how much can I do it? Now, if somebody's doing 12 puffs a day, you have to step back and it's like, what's wrong with this patient? May need something else. So, but you can do quite a bit of it and still be safe. Can SMART be prescribed with other ICS LABA combinations? No. Right? You should not use formoterol and salmeterol in the same patient because it can be problematic. Can SMART be prescribed with ICS formoterol as a reliever And an alternative ICS/LABA as maintenance therapy, no. So this issue about Dulera, for example, comes up all the time. And we do it kind of under the table. And the reason is because there's just no data. But it's one of those things that makes a lot of sense because it's the same reliever and it's mometasone is an inhaled corticosteroid. So if you were able to do the study, you probably show the same thing, but there's no data. So I don't think it's wrong. I don't think it's wrong to do it, but so you know that there's not a lot of backup information behind it. So who should be considered for smart therapy? Who's the ideal person for smart therapy? So patients requiring ICS/LABA in GINA step 3 and 4, particularly those with a history of exacerbations. The people that benefit the most from this intervention are people that exacerbate, because that's where you get the most for your money. If somebody's not exacerbating and their symptoms is very mild and they're happy with their treatment, like it's over here, in which patients may be acceptable or preferable to continue, ICS/LABA plus as needed albuterol. So patients with well-controlled, not exacerbating on this regimen that are adhering to ICS. Like I have patients that, this is like the digoxin story, right? Your patient with heart failure and digoxin, super happy, keep it, right? Like I have patients that come to me that are taking theophylline, which we don't use anymore, but they look at me like, don't you dare touch my theophylline. I'm like, fair game. Like, you're happy with your theophylline, keep your theophylline. If your patient's happy with the treatment, they're doing fine, they're not exacerbating. You have to decide whether it's worthwhile embarking a whole new management approach in somebody who's doing very well, who's adhering to therapy. So it's not for everybody, I think. In patients prescribed SMART, can the maintenance dose be reduced? Absolutely. So I'll show you some data on some approach on step up, step down. This is an interesting one. Do patients need to rinse their mouth after each reliever dose? This is being looked at in post-hoc analysis. Mouth rinsing is recommended after maintenance dosing, but it's not necessary after relief dosing. When people use it sparingly as a reliever, it doesn't lead to increased risk of candida infections in the throat. Yep. Yeah, that has not been looked at head to head. Don't know. It's a good question. The question is whether ICS/LABA and ICS/ABA would be superior to or non-inferior to each other for rescue. Yes. It's better than salmeterol. Yeah, it's very. So if you look at pharmacological data, all pharmacological data, there are differences. So formoterol is very, very fast acting, whereas salmeterol is not a fast acting drug. So that alone precludes it from being used for short relieving therapy. There's data that formoterol leads to a ceiling in terms of cardiovascular effects, whereas salmeterol leads to more cumulative dose response effect down the road. And that's been shown in some pharmacological studies where you see much higher rates of tachycardia, particularly a little bit later after you've dosed, whereas formoterol does not. So from a cardiovascular point of view, formoterol is thought to be a lot safer. That makes sense? And it's a rapid onset drug. Europe, for example, Europe has been using formoterol for decades. We have not. Yes.
Like some feel like they did a similar, like does it take some coaching and
Yeah, it's a great question. I think the question is like, how do patients respond when you take them from an ICS/LABA and plus albuterol as needed for rescue to more of a SMART approach or a anti-inflammatory rescue therapy? It really is variable. I would say that there's, your patients fall into, I don't like to take drugs all the time, and I'm happy taking less, and it's better for my pocket anyway. So, but there's patients that are very attached to and they manage the symptoms and they like what they like. So this is one of like, when I see somebody, I kind of like talk to them about this, hey, we have this new approach of managing asthma. We talk about like, how do we do it? And then I see what the response is. And if they want to try it, typically what I do is I'll bring them back into the office in a relatively short period of time to see how they're coping with therapy and see they're managing well. So it's hit or miss. Some people will come in and say, I love it, best thing ever. And people could be like, I hate it, put me back. So I think you have to just, this is one of those decision-making, shared decision-making process with your patient. You're right, there's patients I don't even mention it. You're doing great, keep at it, you know. So this is an example from a European society where they looked at how to step up and then step down. So for example, for symptom relief, one actuation required. For step one GIM, there's no need for maintenance, but then they start to get more symptomatic. This is where I tell patients, hey, let's say you're doing great, but then you got COVID or you got a virus and you have more symptoms. You can start with doing 1 puff a day plus as needed. And if you feel like you need more, then you can do up to 2 puffs twice a day plus as needed. And then once you get symptom control, stay on it for a few days. And then once you start to get better, start to come down. And people will actually, kind of like when you give them instructions, they actually know, they dose themselves pretty well. They ramp up, they ramp down. So it's a good way to, and I'm a believer that when you do this, you might prevent somebody from going to the emergency room if you allow them to step up. Yes. Yeah. Yeah, I usually don't do 80 micrograms at all. I stick more to 160 because then you can use 1 as reliever therapy instead of 2, which is what the guidelines recommend. There are a lot of practical issues in the United States. This therapy is not FDA approved. It is not supported by most insurance plans, although for some reason in my Epic, there's a new, if you put Symbicort, there's a new thing that says Symbicort Smart RX. And I started to use it and haven't heard anything back from patients or pharmacies. So maybe things are starting to change a little bit. The average retail price for a generic albuterol is $54 on GoodRx, whereas for Symbicort is $322. Even for Breyna is a new generic Symbicort. You know, I actually like, you know, this is what you're doing in real life, right? You're spending time with GoodRx with patients. No, you got to go to Walgreens because right now they're like at $150, you know. So you can get some generic Symbicort for like $150, $200. And if somebody's not using it all that frequently, that may last up to 2 or 3 months. So then it becomes more affordable. But these are a lot of real issues, I think, for these patients. Okay, the last few slides. What happens, for example, now when this is a new thing for us? What happens when you take a patient that was very sick and then you put them on benralizumab, which is what this study did. You put them on a biological therapy and they start to do great. They're like, all the symptoms go away, they start to go into remission, they don't exacerbate, their lung function normalizes, some response to biological therapy is quite dramatic. So what this study did is they randomized in 22 centers, 208 patients that were well controlled based on an ACQ, which is the asthma control questionnaire, had received at least 3 doses of benralizumab, and then put them through a 38-week reduction phase in which they were randomized to, listen, you're going to do continuous therapy, but you're going to lower your inhaled corticosteroid dose to medium or to low dose, or you're going to go, which is the bulk of the patients, or you're going to go just with anti-inflammatory rescue therapy. And this is what we're doing in clinic. So you put them on biological therapy, they stabilize, they're doing great, and then you start to like step down on inhaled medications. And so in this particular study, what they showed in the Shamal study, recently published in Lancet, that the amount of inhaled corticosteroids during the reduction phase actually went down quite a bit on those that were reduced versus maintenance therapy. Just continue with your basically ICS for motor on a daily basis and rescue therapy. And even though their FEV1 dropped compared to those on standard therapy a little bit, and their exhaled nitric oxide went up, what's interesting is that during the reduction period and maintenance period, the annual rate of exacerbation rate and asthma control was no different. So basically, the message is, if you put somebody on biological therapy and they're doing great, you can start to manage them with smart therapy safely. And it's funny because, you know, people do that themselves. They'll come and say, how you doing? Great. This injection you have me on is amazing. I don't use any inhalers at all. And you're like, whoa, that's a little too much. So I think we're starting to tune ourselves like, okay, maybe we can start to manage these patients like if they were on a step 1 and step 2 therapy severity. Unfortunately, FDA recently reapproved after banning it, reapproved inhaled epinephrine. And this is to me a huge problem because again, it's providing bronchodilator therapy over the counter without anti-inflammatory rescue therapy. So I'm not surprising that this will lead to some asthma deaths as it has in the past. But unfortunately, the FDA reapproved it. So what is the FDA response to our asthma crisis on underserved population with low access to therapy? Give them inhaled epinephrine, which is a disgrace, I think, if you ask me. All the societies, all the respiratory societies and general medicine and all societies put out strong statements against this approval, but unfortunately it's here to stay. So I tell patients not to use Primatene inhalers. So what are the pros of this therapy? So the pros, I think there are a lot of pros. There's evidence for efficacy and safety in many thousands of patients, spanning over 12 years of therapy, reduce exposure to oral corticosteroids, less reliever and over-reliance on short-acting beta agonist, safe up to 12 doses a day. It's effective. I didn't show you data. It's effective on people with T2 and so eosinophilic and non-eosinophilic asthma. It's widely available and approved. So MART's approved in 120 countries and AIR is approved in 48 countries worldwide. And it provides a simplicity of regimen for patients and clinicians. I think it's very easy to use for both you and your patients if they're the right candidates for this therapy. There's some limited cons. I think, there's not a lot of people with moderate severe disease with severe airway obstruction that are on triple therapy, for example. There's no studies with mometasone for moral or other combinations. So I think there's some limitations. And there's no head-to-head comparisons, as you mentioned. There are significant insurance and financial challenges in the United States that I think make this therapy problematic. There's lack of regulatory approvals by the FDA, but now they've approved Air Supra, so maybe at some point they will approve for Motorol as well for rescue. And there's limited data in kids, actually. This was, for example, Air Supra was not approved in adolescents and kids. And it's not because people didn't think they're safe, it's just because the data and studies were unstable because the number in the studies is small. So the FDA wanted more data. When it comes to these regulatory approvals, they're very conservative. So that's it. Thank you. Happy to answer any questions. Yes.
Most likely to get it. If someone's using it as needed, should I write it 2 pots BID or something like that? So you get lots of it?
Yeah. I've done it both ways. Lately, I've been putting, I'll say budesonide, and then on parentheses, I'll put Smart RX, so that they know that I'm using that in this capacity. And then I'll say use 1 puff every 6 hours as needed. That's it. If it's just you or that plus maintenance, or 2 puffs plus as needed, depending on if you're doing just air or Smart. But then sometimes I think, and I haven't gotten any pushback from pharmacies. So I think people are starting to know, especially with these new drugs like Air Supra, pharmacists are starting to become familiar with this type of therapy. Because otherwise, what I did in the past was just your regular standard Symbicort, use 2 puffs twice a day, and albuterol, and just 2 puffs. And then I would tell the patient, listen, this is what it says, but then I would write exactly how you take it. So I would be like, don't pay attention. That's like bad medicine. Don't pay attention to a prescription. It's just there for the pharmacist. Let me show you how you're going to use it. So I did that for a long time in order to avoid pushback from pharmacies. But lately I've been doing that Smart RX in parentheses, and it's been working. So you may give it a try, see how it goes. And then, I'll tell patients, let me know if you have any problems in pharmacy, call me, and I'll change the prescription. And I haven't heard back from the insurance as well with this Smart RX. I think people are starting to, and if a patient doesn't have insurance, I'll go with Breyna. Breyna is a generic Symbicort. It's a little bit cheaper, not by a lot, but it's a little bit more affordable. So you can do Breyna in Epic, pulls out the generic compound. So those are some of the practical issues I've learned around managing these patients. It's really funny because if you look at the package insert, Ostelmark, I had a slide, I think I took it off. I had a slide from the package insert on Symbicort. It says, this drug should not be used more than 2 puffs twice a day under any circumstances because it's dangerous for you. And I were like, people take, hey, take it every 6 hours, it's not a problem. And somebody reads the package insert, be like, what are you doing to me? So there's this big lag between changing a lot of things in how I mean, practice has evolved, I think, faster than some of the regulatory processes in this case.
Doing well, and they have albuterol as a rescue. Did you change albuterol to Supra?
Yeah, it's a good question. If they exacerbate, yes. If they have no exacerbations and they're doing great, I don't think there's that much of a benefit. So remember, the real benefit here is exacerbation reduction. So if somebody has had even more than once a year of exacerbation, I'll say yes, use Airsupra if you can afford it, or ICS plus SAP plus albuterol in the next to each other. The other thing you can do is if you have somebody, for example, on Trelegy, on triple therapy, on those like triple compound medications that are now available, one puff a day, you cannot do Symbicort with those patients because it's too much long-acting beta agonist. So the only drug you can do is Airsupra in that case. So for Airsupra for people with triple therapy, that exacerbates a good combination.
There an incentive change them?
Dozen times a month is a lot. So in that particular case, I would be like, yes, you need an anti-inflammatory therapy if you have that degree of utilization, because that to me means that you probably have some degree of unopposed inflammation that's causing symptoms. But if somebody have patients that, hey, I use my albuterol once every 2 or 3 months, when I go work out at the gym, and I even question whether they have asthma or not, I'm like, don't spend any more money, you're doing great.
They're exercising every day, so they're going to take their albuterol or exercise 2 months, like 5 or 6 days a week. And then for in, what do we do with that?
So in those patients, there's actually good data that if they're having symptoms with exercise and they're exercising frequently, you need to control inflammation. So they have to be on some anti-inflammatory therapy, whether it's SMART or a daily ICS or something like that will typically lessen the amount of pre-exercise albuterol requirement and lead to better symptom control during exertion. So it's not all about, yeah. Yeah. If they have 0 symptoms outside of exercise, like there's people that are like, I've never had a symptom outside exercise, and they're doing great with albuterol and they never exacerbate, I'll continue with the same thing. So you have to just see what makes sense for the patient financially and symptom control. And again, if they don't exacerbating, then the benefit is not that great.